The modified knots test is used to concentrate microfilaria and differentiate between dirofilaria and dipetalonema. So it fixes microfilaria and lyses red blood cells. So to start, you want to take 9 mL of 2% formalin. Place this in a test tube. And mix with 1 mL of anticoagulated whole blood. And then mix by inverting. And I'll now allow this to sit at room temperature for 1 to 2 minutes, and then centrifuge for 5 minutes at 1500 RPM. So once done centrifuging, we remove the supernatant, being careful not to disturb the sediment at the bottom. To remove the remainder of the supernatant, I'm going to pipette off the top so that I don't disturb the sediment at the bottom. And now I will add a drop of new methylene blue stain. Now I mix the stain with the sediment using a pipette. And add a drop to a slide. Next, add a cover slip. So I'll now take this over to the microscope and examine under 100x and 400x for microfilaria. So after a thorough examination of the slide, no microfilaria were present. When you're looking at microfilaria, you can determine the difference by looking at body shape, body width, length, and the movement of the microfilaria on the slide. So you'd be using this test for patients that have tested positive for heartworms in the past or suspected heartworms. In this case, I was looking at a patient who had tested positive for heartworms about a year ago and was on the slow kill method. So good news in this case, no microfilaria were seen. I'm going to demonstrate the setup for the direct smear method of fecal examination. The direct smear is a rapid scan for all parasite stages, including trophozoite stages. So it's different than the other tests because it may not examine as large of an amount. It's a smaller amount, so may not be as adequate, but still an important part of all fecal examinations. So to start, we add a few drops of fecal solution to the slide. And then we add an equal amount of stool. And then we're going to mix together using a wooden applicator until the solution is homogeneous. Alright, and then using my wooden applicator, I'm going to spread this into a thin film. And I'm going to remove these large pieces off the side here. And then you want to make sure that you can read through your film as well. So I hold up to a paper with writing. Make sure that I can read through it. I can. Add a cover slip to the slide. And I can now go to the microscope and examine under 100x and 400x for parasites. So next I'm going to demonstrate the setup for the simple fecal float. The fecal floats, unlike the direct smear, which can use saline, and sedimentation method, which uses water, these must use the fecal solutions. So fecal solutions are formulated with a specific gravity that's higher than most parasite eggs. So the eggs are going to float to the top. The type of fecal solution that you use is going to depend on the area that you live in and the parasites you're looking for. Most common nematode larvae are going to float on most common fecal solutions. However, most fluke eggs are going to be heavier than the common fecal solutions, so those will not show up with this technique. So to start, I've already measured out about 2 grams of fecal matter in a cup, and I'm going to mix 30 mLs of fecal solution with my feces here. So once fully mixed, I'm going to strain the emulsion through a gauze square into the vial that I'm using for testing, which is this test tube here. And I continue to pour until a meniscus forms at the top of the tube. So you can see there my meniscus has formed. And I then place a cover slip on top of the meniscus. And now let it sit undisturbed for 10 to 20 minutes. We take our cover slide, lift it straight up, and place it face down on the slide. We can then examine this under the microscope for parasite eggs at 100x magnification. So next I'm going to demonstrate the setup for centrifugal flotation. Centrifugal flotation is not only more sensitive, but it's faster than the other methods. It also recovers more eggs and oocytes than the others as well. So similar to the fecal float, the simple fecal float, you're going to take 2 to 5 grams of feces, which I've got already measured in this cup here, and mix with 30 mLs of fecal solution. And then mix together. And then similarly, again, I'm going to place gauze over my cup, and I'm going to strain into this centrifuge tube. If I was using a swinging arm centrifuge, I would fill all the way until there was a meniscus on top, place a cover slip, and centrifuge that way, then examine the cover slip afterwards. But in this case, I'm using a fixed head centrifuge. Using the fixed head centrifuge, I'm going to fill the tube until about 1 centimeter below the top. Okay. Put my lid on here. And then I have a balanced centrifuge tube here. I'm going to place in the centrifuge. And I'm going to spin for 5 minutes at 1300 RPM. So once finished centrifuging, I remove my tube, place it in the rack, and now I add more solution to the tube until I have a meniscus form on the top. I'm going to be careful not to cause too much turbulence when I do this, because I don't want to push eggs that are floating down deeper into the tube. meniscus is there at the top. Bubble there. And now I add a cover slip. And let it sit for 10 minutes. And then remove the cover slip, straight up, place it on the slide, and can then examine under the microscope at 100x for both eggs and oocytes. Next, I'll demonstrate the setup for fecal sedimentation technique for fecal examination. So this technique is a little bit different than the others. It's a little more laborious. It's also going to be looking for parasites that produce ova that are heavier than your standard fecal flotations and wouldn't show up. So for example, you'd be looking for fluke eggs with this or large animal parasites. So you start with your 2 to 5 grams of feces. Again, I've got that measured in my cup here already. But this time we add 30 mLs of water. And now I can strain our mixture here through gauze. I place that over my cup. And I can now either centrifuge for 5 minutes or allow to sit undisturbed for 30 minutes. So for the fecal sedimentation, I've centrifuged for 5 minutes. We've got the sediment there at the bottom. So next you're going to either pour or pipette the liquid on the top out of the tube, the supernatant here. So I'm going to come over here and do that. But I'm going to be careful to not disturb the sediment at the bottom. And all of the liquid out of the top. Okay. So I'm left with just my sediment there. Next, you can either pipette or use a loop to take a little bit of the top layer of the sediment and place it on the slide. Then you apply a cover slip. And can examine under the microscope. For urine collection, ideally we collect urine via catheterization or cystocentesis, but sometimes it's easier to collect a voided sample, and sometimes owners are asked to collect those spontaneous voided samples at home. So to start for that, you want to first clean the prepuce or the vulva. So I'm going to clean with a little bit of Chlorhex solution that I have in this bowl here, and then rinse with some sterile saline, and that will hopefully decrease any contamination, or some of the contamination, when we collect our sample. And then I'll rinse with a little sterile saline. Alright. And you also want to make sure you're wearing gloves and you have a clean container. Doesn't necessarily need to be sterile. So for voided sample collection, you're also going to try and collect midstream to help decrease contamination as well. Alright, so we have our collected sample here, and just looking at the characteristics, I can tell it's kind of a dark yellow. It's clear, I can see through it, and it also doesn't have like a sweet odor or anything, no hematuria, no indications of biopigment in there. The best time to collect a voided sample is going to be preprandial morning samples before pets have eaten. This is because it's going to be the time when it's most concentrated and least affected by dietary factors. Cystocentesis is used to collect a sterile urine sample. It's only used when the bladder is distended enough to be easily palpated. So there's two ways that you can do that. You can do a blind stick, in which the patient can be standing, or in lateral or ventral recumbency. and you would palpate and immobilize the bladder. But secondly, like I'm demonstrating in this case, we'll do an ultrasound guided cystocentesis, which means I use the ultrasound probe to take a good look at the bladder, make sure it's large enough to collect a sample and that my needle is entering the appropriate area. So you're going to enter your needle in the caudal abdomen. I'm going to direct dorsocaudally, and I'm going to enter at an oblique angle. Once in the bladder, you can apply suction and aspirate urine. Once the sample is collected, release pressure, release suction, and withdraw the needle. So just looking at this sample, looking at the characteristics, I can tell it's a light yellow. It's slightly cloudy. I can't tell an odor with it in the syringe this way, but we can now take this to do a full urinalysis. You use a 20 to 22 gauge needle that is 1 to 1.5 inches long, and we change the needle before we transfer into a test tube. That way we decrease any contamination, whether it be bacterial or blood, from when it enters or exits the abdomen. Catheterization is used to collect a urine sample in the case of a culture insensitivity if a cystocentesis can't be collected. So there's a couple different types of catheters you can use. There's polypropylene, which is a little more easy to get in. It's stiffer, so it could be a good choice for cases where you need to unblock a patient. There are red rubber catheters, which are a little more flexible. And there are Foley catheters, which have a little balloon on the end that you can inflate. So a good choice if you need a catheter to be placed for a longer period of time, or for female patients who have shorter urethras. So this is Adolf, and he's being sedated for this procedure. During the procedure, we will show proof of monitoring and unassisted chest movement. To start catheterization, your patient should be in lateral or dorsal recumbency. You want to extrude the penis by pressing caudally at the base and cranially at the prepuce. And then we can sterilely clean the penis using an aseptic solution. I'm using a little bit of Chlorhex. I'm going to scrub the penis. And then rinse with some sterile saline. I'm going to go ahead and aseptically put on some gloves. So Dr. Crum is going to open our sterile lube packet. He's opening sterilely and placing on the inside of our glove pack, which is also a sterile surface. So when we're ready, we can then place the tip of the catheter in this sterile lubricant and then insert into the patient. So we have sterilely prepared our catheter here. I'm going to go ahead and estimate the length of the catheter by holding next to the patient. Now apply our sterile water-soluble lube to the tip of the catheter. So Dr. Crum is helping again to extrude the penis. We've already aseptically cleaned, as I showed before. We can now enter the catheter, place the tip of the catheter at the distal urethral orifice, and gently insert. until you reach the lumen of the bladder. And you want to be careful not to go too far, which is one of the reasons why we estimate the length beforehand. And then to collect urine, we first collect the first couple mLs here. And we're going to discard those due to any possible contamination from when we place the catheter. Alright, so we're going to discard the first couple mLs of the urine collection, and we can then take a urine sample for urinalysis and culture. And then once you're finished collecting your sample, you can then gently remove the catheter. So looking at the characteristics of the urine we collected via catheterization, it's a dark yellow and it is pretty turbid, it's cloudy, and I can tell this because when I hold it up to words, those words are blurry and I can't read through it. So those are just a few of the characteristics. And ear cytology is indicated if a pet is scratching or itching at their ears or shaking their head excessively. It would also be indicated if you're seeing excessive debris, redness, or inflammation in the ear. All those things could indicate that infection may be present. So when you're taking ear swabs, we use cotton-tipped applicators, and you always take a swab from both ears. You want to make sure you're far enough in the canal where you can rub and get a good sample, but not far enough where you're going to push the debris down to the ear canal or potentially harm the ear, or the eardrum, excuse me. You don't want to push the debris down to the eardrum or potentially harm the eardrum. Alright, so you're going to lift your ear pinna, put your swab in the canal, rub to get a good sample, and remove. You can see the debris I have on the swab there. So I'm going to break this swab so I know that this is the left ear. I'm going to do the same for the right ear. Lift the pinna, get my swab down in the canal, far enough to get a good sample but not pushing too far down. Got the debris on the swab there. Then I can take my slide. I have the frosted side up, and you're going to roll the swabs on the slide. Remembering to take note of which is which ear, leaving a space between. I'm going to roll the swab on the slide. There we go. So if you can see. So we have our slide for ear cytology. You're going to gently pass it through flame and then stain in Diff Quick. So for any stain, you're going to follow the directions of the staining kit. For Diff Quick, you can dip in each stain for about 10 seconds, and then we'll rinse with water. Water here. And I'm going to allow to dry for just a few seconds while I get the microscope ready to examine. So after staining, I place my slide on the microscope stage, and I start by focusing at the 4x magnification. once focused there, I can move to the 10x, and I use the fine focus to continue to focus at this setting. Can then move to 40x magnification and focus here. Then before moving to the 100x magnification, I place a drop of immersion oil on the slide. And focus again. And I can now scan the slide for yeast and bacteria. After reviewing the ear cytology thoroughly, scanning the left and the right ears, I'm actually seeing no bacteria, no yeast, really just seeing more debris and wax. Fungal cultures are indicated in the event of any sort of lesion, especially those that don't initially respond to appropriate therapies. So cultures are going to allow you to really diagnose the true cause of disease or the cause of those lesions. So what you're going to be looking for your dermatophyte cultures is going to be a new and emerging lesion. You're going to want to take your sample from the periphery of those lesions. You can do this in a couple different ways. You can use swabs, forceps, or the toothbrush technique, or hair plucking, which I'm going to be demonstrating today. So I'm using sterile hemostats here. And ideally your sample is going to glow under the Woods lamp, but that's not the case in every sample. So in this case, it's not glowing, but I'm still taking my sample from the lesion, from the periphery. I'm going to pluck, ideally trying to get 10 to 20 hairs. And then you can take your sample over to the apply our sample to the medium here, pressing it into the media, but being careful not to bury it. Just pressing it gently into the media there. If I was using the toothbrush technique, I would scrape the area at the base of those hairs and then press the bristles into the media. So we'll now incubate this in our incubator. Colonies usually form in 5 to 7 days, but you want to incubate at least 21. To evaluate the dermatophyte test medium, you're going to be looking at kind of gross colony growth and then also color change. So the colony growth more commonly is going to be white fluffy colonies. Some are going to be pigmented. If it's really incredibly pigmented, it's probably a contaminant. And then your color change you're looking at on the DTM trays is going to be a red color change. So in this case, just visually examining, we're not seeing any colony growth or color change, but really you can't definitively diagnose based on that. You also want to examine microscopically. So what you want to do is open up. You're going to take a piece of clear cellophane tape. You're going to press down to touch the colony. And then transfer your hyphae and your fruiting bodies over to a slide that already has some lactophenol cotton blue stain on the slide. You're going to place it with the sticky side down. And then bring over to the microscope here. And we're going to examine under low power the microscope now. you're going to be looking at the hyphae, you're looking at the macroconidia, and you're looking at the structure of those presentations, the layout, how it's presented on the slide, cell structure. For example, microsporum are going to be more canoe-shaped. So the structure and presentation of the fungi on the slide are going to help you to identify what you're looking at. And in this case, our DTM is negative. I'm not seeing any growth on the slide. I didn't see anything visually. So in this case, there was no fungi growth that was contributing to the skin issues of this patient. Skin scrapings are indicated in the cases of alopecia, pustules, crusting of the skin, itching. Any of those things can indicate that an ectoparasite may be present. So the area that you're going to do your skin scraping is going to be indicated by the affected areas, and then also the areas that are known to harbor parasites. So you can do a deep skin scraping, which is going to be looking for demodex, which live in the hair follicles and sebaceous glands. Or you can do a superficial scraping, which is going to be looking for scabies, lice, and those more parasites that live on the top layers of the skin. So to start your skin scraping, you want to take a few drops of mineral oil and place it either on the slide or on the patient's skin. I'm going to place it on the slide here. And take a number 10 scalpel blade and dip it in the oil just to coat your blade. And now I'm going to come and squeeze the skin, squeezing the area that I'm doing the scraping. If I was doing a deep scraping, I would first shave the area with a number electric clipper blade, or number 40 clipper blade. But in this case, I'm just doing a superficial scraping, so I don't need to shave. I'm going to scrape a 3 to 4 square centimeter area in the direction of the hair. And if I was doing a deep scraping, I would do this long enough to see capillary bleeding. In this case, since I'm doing a superficial scraping, I'm just scraping enough to get debris on my blade. I don't need to see that capillary bleeding. So once I have my debris on my slide here, on the scalpel, I transfer it to the slide by again dipping my blade in the mineral oil. And I'm going to transfer all that debris over there. So in both types of scrapings, in a deep or a superficial scrape, you want to do multiple areas on the body. For superficial scraping, good areas are going to be the ear margins, the elbow, and the ventral trunk. So after taking the skin scrape, I place a cover slip over our result on the slide, and I can then take it to the microscope, place on the stage, and I'm going to examine with the condenser down. So I'm going to examine this slide now at 4x to look for any mites or mite eggs. A necropsy is a post-mortem examination which is important to diagnose the cause of death, diagnose the disease process that led to death, confirm a diagnosis, and also examine the positive and negative effects of therapeutic agents. So when doing a necropsy, you want to make sure you're in a well-lit, well-ventilated area that can be easily cleaned and has adequate drainage. You also want to make sure you're wearing plastic or latex gloves, a gown or an apron, a mask, eye protection, and protective footwear. We also use instruments that are dedicated only to necropsy so that we reduce the spread of any pathogens. So this is going to include using necropsy knives, scalpel blades, handles, forceps, hemostats, bone cutting forceps or saws if we needed those. Our patient is very small and we did not need to use those today. Those are all important things that you want to include in your necropsy. In addition, you also want to make sure you have your collection jars ready. These are the sample jars we're going to be using for the fixed tissue samples. It's 10% neutral buffered formalin. So we have 2 of those for both of our samples. You can also use sealable and labelable bags. You want swabs if needed, culturettes, and things to be able to take your samples in. For the necropsy, you'd always make sure that you have owner permission first to perform the necropsy and that you've correctly identified the animal, so you're performing the necropsy on your correct patient. We would then discuss signalment, history, clinical findings, and weigh the patient. And in the interest of time, since we're not showing the entire necropsy, this has already been done, and our patient was 0.51 pounds. So Dr. Gatewood can now begin a brief external exam.
All right. So just first of all, we'll just take a look at the kitten's little face here. I don't see any nasal discharge. I don't see any diseases in the oral cavity. Of course, the eyes are very dilated, but no other ocular diseases noted. The ears look nice and healthy in there. We'll just do a quick comb for external parasites. Oh, I do see a little flea. So this kitten has fleas. The one thing I will note on this kitten is there is what looks like some fecal material, diarrhea, and it's almost very yellow tinged, so I'll be interested to see what this kitten's intestines look like.
So next we would normally remove the eyes first and take a look at those, but again, since they're not showing the entire necropsy, Dr. Gatewood can move into making her midline incision and brief internal exam.
I'm actually going to turn this kitten around here and help me hold it down here. Alright, so we are going to make a midline incision with our scalpel. We're going to start right at the end of the sternum here, and we're going to go all the way to the pubis. So to be careful with this kitten's skin because it's very thin. We don't want to puncture right into the abdomen. Ooh, it's very thin, isn't it? Alright, and this kitten's skin is actually so thin, she doesn't have much of an abdominal wall here, so we're just going to poke on into here. I'm actually just going to use scissors so I don't cut anything. If I can grab it. Okay. All right, and just looking around, I don't see any free abdominal fluid. I don't see any major hemorrhages. The intestines are a nice pale pink color. Let's see. Her stomach is definitely full with digesta. Her spleen is normal and small. You can visualize all the way down to the kidneys. And I don't see any evidence of abscess formation or anything scary, just looking around the peritoneum. So our next step would probably be to get a couple samples. Ideally, we would take a small sample of everything, but for this video, we'll start with a sample of the liver. And I think it's important to note that when you're taking these samples, you don't want to crush anything. And since I don't see any obvious lesions on the liver, I'm probably just going to take a small sample of this little liver lobe here, which is pretty readily available. And we've got some pretty good sized formalin jars, so I'm just going to take a nice little chunk here. I'll be very careful with it. Don't want to touch the formalin. Oh, that went right in. Perfect. And then, just since this kitten was having some diarrhea, we probably do want to get a biopsy of the GI tract here. It is ideal to do this last because the GI tract is full of bacteria, and we don't want to contaminate the abdomen. And Kelly is going to label all of our jars for us so we don't get any tissue samples mixed up.
And so when she's taking these samples, it's my job to assist. I make sure that the jar stays completely closed until she is ready to put the sample in the jar as well.
And this is the jejunum here, so I'm just going to take a nice full thickness biopsy.
And like Dr. Gatewood mentioned, we make sure that the tissue is not stretched, squeezed, rinsed, or rubbed before being placed in the jar. If it needs to stay flat, then we place it on cardboard and then put it in the jar. And once it's in there, then I label each jar with the necessary identification. So I have our date, the patient name, and can now put the area or the sample source here at the bottom.
Alrighty, so for closure for this baby, we'd probably want to go on ahead and suture the whole thing closed. I would probably just do one full thickness suture closure.
And what we didn't show would be the rest. We would do immediate dissection of each body part moving forward to finish the necropsy. If we needed to take fresh samples, swabs, culturettes, things, we could do that as well. For collection of vaginal cytology samples, you want your patient to be standing with the tail elevated, so it's not going to fall and contaminate your area. And you start by cleaning the area with a chlorhexidine solution, which I have in the bowl here. So I'm going to clean her vulva here. And then I'm going to rinse with sterile saline, which I have in this jar here. So next, if I was using a speculum, you could now insert a sterile lubricated speculum just above the urethral orifice into the vagina. But if you're not using a speculum, you can go straight to using your sterile swabs. In lieu of the sterile swabs, I'm going to be using a sterile culturette swab. So it's sterile in the package here. And I'm going to open my swab, being careful not to touch anything else. And I'm going to moisten the swab with some sterile saline. So then I'm careful not to touch anything else. I can now part the vulva. And insert the swab at a steep, nearly vertical angle for about 1 to 2 inches. Then adjust horizontally 45 degrees and continue to insert. So once fully inserted, you can make 2 to 3 revolutions with the swab. Then gently withdraw. So I'm going to now immediately take my swab and roll it onto a slide. So I'm going to make sure to roll and not rub. And we can now take our slide to the microscopic area to examine under the microscope. For vaginal cytology, we're then going to stain it. So you're going to dip 5 to 10 times in a fixative and a stain. For vaginal cytologies, Diff-Quick is a good choice. So I'm going to dip 5 to 10 times in the fixative, the red, and the blue stain. I'm going to rinse with some water. And you can now examine the slide while wet, or you could dry the slide and place a cover slip on it and then examine that way. So I'm going to go ahead and examine immediately here. I'm going to get my field of view focused. And I'm going to examine at 40x. Here, what I'm looking at are not cornified epithelial cells. They have an abundant cytoplasm, a round, large nucleus. I'm seeing occasional neutrophils. I'd call the epithelial cells intermediate cells. Not seeing any red blood cells, and not seeing any bacteria. So, in conjunction with our patient's history, in this case, also what I'm looking at microscopically, I'd say this patient is an anestrus. Those are the things you'd be looking for in this stage, and then behaviorally, you're really not going to see any signs. This is when the reproductive tract is at rest. If it were proestrus, I'd be seeing parabasal cells, basal cells, superficial cells, some neutrophils, some bacteria, and I'd be seeing a high number of red blood cells if it were proestrus. Behaviorally, in that case, you'd be seeing males attracted to the females. You'd see vulvar swelling and some discharge, but the female would not mate in that case. If it were estrus, I'd be seeing primarily superficial cells that are cornified and anuclear. You may see some red blood cells during estrus, a few there, but in general, also neutrophils are absent in that stage. Behaviorally in estrus, you're going to see the female stand and be receptive to breeding. You'll also see a discharge that's pinkish that gets whiter as estrus progresses. And then lastly, the last stage of diestrus will look microscopically like anestrus. You're going to see the return of your non-cornified epithelial cells, but you'll also see kind of abundant cytologic debris. Also behaviorally in diestrus, your patient's going to have a history of estrus and no longer accept the males to mate. You're going to have decreased swelling and decreased discharge. If it were during pregnancy, also your cytology is going to look a lot like anestrus and diestrus. Cross-matching is used to blood type match dogs and cats that are going to be used for blood transfusions. So a major cross-match takes the recipient serum and adds it to donor cells to make sure there are no agglutinating or hemolytic antibodies present that are against the donor antigens. So a minor match does the opposite. It adds donor serum to recipient cells, but if a donor previously tested negative for antibodies, then a minor cross-match isn't necessary. For cross-matching, you draw a blood sample from your donor and your recipient and divide the sample into a red and yellow top tube and a lavender top tube. Allow it to clot and centrifuge my clotted blood samples. After spinning in the centrifuge, I will now transfer the serum from my red and yellow top tube to a plain red top tube. I'll do this for the donor sample and the recipient sample. So this is my donor sample. And I've transferred the serum, and now I'll do the same for my recipient. Next, we want to centrifuge our EDTA tubes so that they spin down and we can remove the plasma. Okay. After spinning in the centrifuge, we can take the plasma off the top of our sample. So I'm removing the plasma. And I now take 2 drops of the remaining erythrocytes and place them in a separate test tube. And I can now fill the remainder of the tube with saline. And this is going to wash the erythrocytes. So I'm now going to mix by inverting. So again, I have a mix of 1 to 2 drops of just the erythrocytes and filled the rest of the tube with saline. And I'm now going to centrifuge this at 1 minute at 3400 RPM. This is the first wash, and this is for the donor. I'm going to do the same thing with the recipient. So after spinning in the centrifuge for the first time, I'll now remove all of the supernatant and then repeat this process 2 more times for a total of 3 washes for the donor and the recipient samples. So I'm going to do the same thing. I'm going to remove the supernatant, take 1 to 2 drops of the erythrocytes left, place them in another tube, add saline, and so on. So it's now after the 3rd wash. I'm going to remove the supernatant again. After each time I spun down, I wanted to make sure that the supernatant was clear and colorless, meaning that I washed the erythrocytes properly. So I'm going to remove that supernatant 1 more time. So I'm now left with just erythrocytes at the bottom, and we now make a 2% erythrocyte suspension. So I'm going to take 0.02 mLs of these washed packed erythrocytes and add it to 0.98 mLs of saline. And this is my donor sample. So 0.02. And I'm going to mix that with 0.98 mLs of saline. So that is a 2% erythrocyte suspension. I'm going to do the same now with our recipient sample. So now I'll take 2 drops of the recipient serum and 2 drops of the donor cell suspension and place it in a new tube, and this is going to be the major cross-match. Now I take 2 drops of the donor serum and 2 drops of the recipient cell suspension, put that in a new tube, and that's the minor match. Next, I mix 2 drops of the recipient serum with 2 drops of the recipient cell suspension to make the recipient control. Lastly, I make the donor control by placing 2 drops of the donor serum and mixing it with 2 drops of the donor cell suspension. Place all of my tubes in a test rack and then gently shake to mix. And I now let these incubate for 30 minutes at room temperature. We now centrifuge all of our samples for 1 minute at 3400 RPM. So after spinning in the centrifuge, I take a look at each tube. I'm looking for any hemolysis, and I kind of shake and gently tap the tube, looking for any grossly visible agglutination. So this is the major cross match I'm looking at. I don't see any visible agglutination there. This is the minor cross match, no hemolysis, and no grossly visible agglutination in that one. And then I also take a look at our control samples. There should be no hemolysis in your control samples, so nothing there. And then the last control sample as well. So since there is no grossly visible agglutination, I'm now going to take these and place a small amount of each onto a slide and then check for microscopic agglutination. For the major, minor, and both controls, I have a slide for each, and I bring them over to the microscope, and I'm going to examine with the condenser down at low power. I'm going to examine for any agglutination. So I've looked at each slide under the microscope, and in each slide the red blood cells are evenly dispersed. There are no clusters, more like kind of grape-like clusters. That would be agglutination. There is no agglutination in either major or minor cross-match, so that means that a transfusion between those patients would be viable and okay to perform. If I saw any hemolysis or agglutination in either of the cross-matches, then you would not want to perform that transfusion. Similarly, if we saw any hemolysis or agglutination in the controls, that would indicate there is some autoagglutination or contamination of the reagents, so it would render your cross matches uninterpretable, and you would have to repeat those results.